will be moderating this next session. He's got a great group of panelists for you. I do want to thank Smith Nephew for sponsoring this hour. So Dave, take it away.
Good morning. Thanks, Selene. And good morning, Anish and Constantine. I know Chris will be on momentarily. All right, so let me get my screen share here. The way this will work is I'm going to give just a short introduction on ankle replacement, revision ankle replacement specifically, and then we'll just go through cases. The Constantine and Anish, your cases are intermixed in the slide deck. So just when we come to them, I would just ask that you present it. I'll just advance the slides as we go through your cases. Okay, so revision total ankle replacement. And we have our panel. A bunch of disclosures. Today we have myself. I'm at Rothman Orthopedics in Philadelphia. We're lucky to have Anish Kadakia from Northwestern University. We have Chris Hyer from Westerville, Ohio, and Constantine Demetrocopolus from the Hospital for Special Surgery in New York. So total ankle revision. Well, total ankle replacement, as we know, is a challenging procedure, but revision total ankle replacement is even more challenging, right? There's bone loss, deformity, poor soft tissues, and for some patients, revision is not even really an option. And when we look at sort of the landscape of like primary total ankle replacement, there's a ton out there, right? They all like kind of look the same, but there's so many things from ceramics to vitamin E poly to 3D printed ingrowth surfaces. There's a lot of available options, especially even just talking about fixed and mobile bearing. But when we go to revisions, there's really not much, right? These are the two revision systems available in the market, the Stryker and the Smith and Nephew options. So there's not a lot there. And so my personal journey with ankle replacement is kind of as follows. I trained with Roger Mann. I did the STAR mobile bearing 3-piece device starting in 2006, and I used it exclusively for 5 years for what I thought were some challenging cases, and I thought were pretty good results. And then I kind of would use a fixed bearing implant when I wanted like more stability. And I don't know that that was really giving me more stability. That's kind of the way I thought about it. And I added a stem for cases of like bone loss or revision. And then I sort of used a flat cut talus if I thought there was some bone stock deficiencies or revisions. And this worked okay. But now we have many more primaries, which means we have many more revisions to do, and not a lot of guidance. If you look at the data, if you look at this 2023 systematic review in foot and ankle clinics, there's only really 12 studies with 4 years of follow-up and only 6 with patient-reported outcome measures. This is a recent study from 2024, medium-term functional results, 25 patients, 5-year follow-up, 24% complications and a 96% survival rate, but 78% if you consider failure, the need for another operation. So, like, I'm not being critical of our profession or of our attention to the need for more data. We just don't have a lot of data. I think many of those on the call have partners who are doing 700 or 800 total knee and total hip replacements a year. Well, if you have like an army of people doing those replacements, then it's not that difficult to get the data. But in many practices, even academic practices where people are doing a dozen, 30 of these a year, in urban centers where people move, it's difficult to get these results. So we don't have a lot of guidance. We don't have a lot of implant options. And so it's a challenging environment and landscape for us to navigate. So we push on with good technique and we continue to publish our outcomes. And that's how we will continue to make progress as we've done for many years. So case number 1, this is a 55-year-old female, 2 years out from a Salto total ankle replacement that was done somewhere else. No history of infection. She has pain, and that's her larger X-ray. There's her, that's the axis in which the implant was put in. That's kind of, I would say, her mechanical axis. Her anatomic axis is obviously altered by a malunion of the tibia. And so I would ask the panel, like, what are the options? Do you start trying orthotics. Do you ever give patients an injection? Is this like an osteotomy, a revision, both components? Constantine, Anish?
So I know Constantine's done this too, but I would say if her pain is medial, my gut is, and I think all of us on the panel will think the same thing, she probably is overloading that medial corner of that implant. And so if you have access to a spec CT, that would be awesome. I don't. But my gut is because of the mechanical alignment, because the implant itself looks okay. I don't see a cyst. We don't have a lateral, obviously, but assuming that looks okay, I think it's the mechanical axis. So I don't waste my time with orthotics because that fixes the hind foot, doesn't really affect the primary issue. And I think she needs an SMO, fibular tibial osteotomy, to put that mechanical axis back to the back to neutral. That should fix the problem. Revising the component, I don't think makes any sense because you haven't solved the problem.
What about like debriding that medial gutter?
Sure, you could do that at the same time. Absolutely, nothing wrong with that. You can make a small. You can either do it minimally invasive now, which is what I do. I just take the burr. If the implant's okay, take that medial gutter down, prophylactically put a little screw up in that area just to minimize any stress reaction. But just doing that, I don't think is a great idea. The osteotomy plus, that's probably your best option for me.
Okay. Do you get any additional imaging? Like when you do an ankle replacement, do you get like full length x-rays? Or like in a patient who had like this, like for instance, a malunion of the tibia, would you get like a full length, not quite a scanogram, but you know what I mean, from knee to heel?
For deformity, yes. Prior injury, deformity, I always get full length films. Normal total ankle, no history trauma, I don't. I don't know if everybody else, Constantine, I don't know if you're doing that all the time, bro.
So I don't. I think if to your point exactly, if they report a history of a tibia fracture, or they obviously have had some injury with deformity, or if when they stand there is a lot going on, right, from hip to ankle, then I will usually send them after the visit so that I have time to study it before I give them any answers about it, because it's not always so obvious. Many people have malalignment due to some subtle, knee issue, bow in the tibia, or in this case, history of a fracture with a malunion. And at the index surgery, you can't pretend like it's not there, right? I mean, if you cut the tibia, if you cut the tibia perpendicular to the mechanical axis, it's going to be very difficult to balance the ankle joint because of the ligaments, and because the axis of the ankle joint is wrong. So you can't just put an ankle replacement perpendicular to the mechanical axis and have it work. So you have to either make the decision to correct the deformity ahead of time at the same time as a replacement. Sometimes I'll compromise and I'll split the difference and try to get away with it. And I don't have data to tell you how well that works or doesn't. But I don't routinely get them on everyone.
Now, so I did not do this replacement, but I can imagine a scenario where on the top left photo, that's what the surgeon was seeing almost the entire case, because of the narrow sort of field of view that you get from the C-arm. Do you guys do anything differently, or is it just basically the preoperative planning that was poor in this case?
Well, not to throw shade, but I think this is a case, this kind of situation, you have to look at that case beforehand, because the x-ray in general, when you do the fluoro, you're really just focusing on the ankle. Even if you get a longer leg shot, at that point, you're not thinking about the distal tibia, and you bought it, right?
Right.
It's hard to compensate. So if you're using a pre-op CT cutting guide, it'll probably, like Constantine said, sometimes it'll correct intra-articularly for sure, and I've done that too. But that decision was already made. So yeah. I don't know if it matters what the heck you're seeing intra-op, because you've made that decision already. And the only thing that we can do in our brain is to make sure it goes up the pike a little bit. But what would you do now? I mean, I guess, you have the pin on the AP. You could cheat at this point and put it up the pike. But I'm pretty sure that surgeon made that decision already before he started. But yes, you should be looking up the entire shaft, and you can get a longer leg view you can see that for sure. But then, you got parallax. So at that point, it gets really complicated.
Yeah. So this implant's not loose. And so I don't typically get full limb x-rays. I do kind of what you guys do. If there is a deformity, I get a longer x-ray. So here's my thought. I did a tibial revision with a poly exchange. I thought, and you're right, the original problem is overall limb malalignment, right? But an SMO takes a long time to heal. It's a hard procedure, especially through, you could do it through just the metaphysis, but then you're getting into an area that would make a revision more challenging in the future, especially with, these can go on a non-union. So maybe you're right, Anish, I took sort of a little bit of an easier route.
No, so it's funny. When we do these panels, it's very easy to be extremely, quote unquote, like ivory tower objective, right? It's easy. I'm not looking at this patient. I'm not dealing with your non-union. It's easy.
Right.
What I would do, 100%, I don't have an answer actually, because it's bullshit to tell you, oh, I would just do this. It's just, we're given the theoretical answer. In the real world, who knows? So I took this has been kind of a nice technique. This is from one of my joint surgeon partners. I use a tiny microsagittal saw because this implant's ingrown. I just use the tiny microsagittal saw to go along the entire line of the implant. That tiny one that sometimes people use for hammer toe corrections. Because then it you don't take out a bunch of bone when you do it. I rotated the implant and then I bone grafted the defect. And then, so here's what I had, and you could say that's probably not perfect, but it is sort of at least better than what we had before. I think it's fairly mechanically well aligned. Whenever you do something like this, I would wonder what people think about weight bearing status post-op. I did not revise the talar implant. And should I have fixed the medial mal? Because what's your weight bearing status post-op for something like this? Is it what you would normally do, or are you altering it a little bit, Constantine?
So I'll just point out, I normally will let them bear weight at 4 weeks, and I might keep them in the boot a little bit longer, but usually somewhere around 8 to 10 weeks or getting into a shoe. So I'll do 4 weeks in this scenario. I think the two things that you did that you didn't mention, but it's obvious, is you debrided the gutter and you upsized the poly. So you distracted the two bones apart. Yep. Which really helps with gutter impingement. So if you can do that, that's key. And so that's my protocol. The other thing I would give a shout out to for those listening is, and I don't know to what degree you did this, but always get ESR CRP and I always aspirate. If there's no fluid in the joint, I tell them not to inject and re-aspirate because I think that doesn't work very well. But I'll get ESR CRP. I'll do a radiology. We'll do an ultrasound if there's fluid to take it out. And then at the time of surgery, I always send cultures because and pathology, because you do enough revisions, you're going to get burned. What's obvious is obvious, but sometimes some indolent infection is there, and it can get you into trouble if you didn't check. So
those are great points. I do the same in any revision. I take some tissue sample and I do take cultures the minute I see that fluid when I open up the joint capsule. I have been totally unimpressed with joint aspiration preoperatively, in that I stick a needle in it and I get like a drop of something that I can't even get in a tube. So that kind of is unsatisfying. I'll tell you one thing. So 3 weeks post-op, this patient had redness and itching at the tibial jig pin site. She refused to come in. Just like itching, you know, that pin that goes into the tibial tubercle. I gave her some PO antibiotics. She ultimately ended up getting an ipsilateral total knee infection. She had a total knee on that side, and the pin site went down to the cement mantle. Just a word of caution. That can happen.
Dave, it's almost like you needed a clamp for the proximal tibia instead of a pin.
Correct. Exactly. Yeah. Yeah. So, yes, we've been talking about that for a long time. All right, case number 2.
Actually, Dave, Constantine, there's a follow-up question to your comment. What happens if you do the revision and then the results of the cultures turn to be positive?
Well, then you treat them. Usually what I've done is I've treated them with, I don't know that that's actually happened to me, but what I would do is I would treat them with IV antibiotics for 6 weeks, and then oral antibiotics for 6 weeks. So that gets them to 3 months. And then I'm going to suppress them with oral antibiotics forever. And hopefully that works, meaning that they have oral antibiotic options that would work for the infection, and that there is a good option that they can take indefinitely, because some of the antibiotics can cause neutropenia or abnormalities, electrolytes that you don't want them to take forever. So I do a chronic suppression, and then every year they come in and we have to have the discussion, should I stay on my antibiotic? And I tell them that they're doing well, so they should just stay on it. And we do that once a year forever. And that's what I would do. I wouldn't take them back to the OR. Obviously, if the whole thing doesn't work apart, then you would need to do a 2-stage revision or conversion to an arthrodesis.
Got you. Dave, another question here comes out. You did a total ankle, patient ends up with a tibial fracture. Is your indication to treat the tibial fracture more aggressive now that they have a total ankle, or are you still not necessarily as aggressive of fixing a tibia fracture?
The most common complication of ankle replacement is a fracture, and the most common complication of revision total ankle is a fracture, and it's much more likely in a revision. So it's something we worry about a lot. I tend to be aggressive fixing these because it's easier to fix it early than it is if it displaces. So if there is a fracture noted, I think putting in a buttress plate or a screw or jumping to an SMO at that time makes sense, and earlier is better than later.
All right, great. Okay, so case number 2. So this is a 71-year-old male, ankle pain, failed conservative treatment, underwent a STAR that I did. He was doing great, no pain. At a year post-op, he's so happy he has no pain, he starts digging for a garden project, and he jumps on the shovel. And so he gets some pain here. So right off the bat, is this, Chris, is this screws? Is it a plate? Is it a cast non-weight bearing for you? Like, how do you approach like just like an acute, periprosthetic fracture that's pretty well aligned?
Yeah, it's obviously, I probably wouldn't try to cast this. It's in a bad spot. It certainly could lead to instability, especially since it's not a stemmed implant. If this was a traumatic fracture without the implant, we would be pretty aggressive with it, but certainly with the implant, I would try to just do screws and kind of keep it MIS if we could. And if he's healthy and he can be reasonable to keep off it long enough, it should heal pretty uneventfully. But I also wouldn't, the first sign of this thing starting to tilt or something, it might need a plate. But I would try to keep it easy and keep it with screws.
Yeah, and that's what we did. ORIF 2 screws. He was non-weight bearing for 6 weeks. Is anyone any different? Like, are you anyone longer or shorter with weight bearing? Just shout out if you are.
Mm-hmm.
Okay. All right. So he's doing well. 2 years post-op. I start to notice this. Do you see that like sort of lucency right around the tips of the screws? And I don't really think much of it. Here he is 6 years post-op. Right? No pain at all, right? He's super active. He's in his 80s. He's got these cysts around the implant on, the AP and the lateral. So as we all know, these mobile bearing implants, they do have some cyst formation. Chris, do you want to just sort of round us through your thought process on this? Because we've all seen lots of stars that have had these.
Yeah, certainly. I guess what makes me pucker up a little bit on this one is that the cysts, we saw the motion or we saw the change first at the screw tip and not behind the implant. So I kind of like our last case, I'd be a little, or yeah, the last case, I would be a little concerned that there might be infection here or osteo from putting the screws in, because it seemed to start there, and then later we see this kind of periprosthetic cyst. So I think first here would be, maybe some infection workup, and look at the patient, see if he's complaining of anything that seems like indolent infection. But that would be kind of my first concern.
So that's a great thought process. We did get the normal lab work, ESR, CRP, and I actually had it biopsied, under CT, because I was concerned that maybe it was an infection. It was kind of a weird scenario. It was sterile.
It was all fine. Okay. Yeah. So I think, with these, certainly get the CT to evaluate what kind of bone you have left to work with. We're focusing on the tibial side, but sometimes the talar side is just as bad, if not worse. So we have to kind of see what bone we're going to have to work with. And for me, this would be a revision to a stemmed implant. But you got to be ready to do some
with no pain.
Well, that's a good point.
Because obviously this is 6 years. At 5 years, he had some of this too, and I was sort of like, okay, well, we'll just continue to watch it. He still had no pain.
And Chris, the dude is 80 years old, man.
Yeah, that's a good point. That's a good point. I would be very open with him. I would really show him what you're seeing, and tell him that we're going to watch this. This is a problem. If the implant starts to tilt or collapse or change angulation, then he's going to have to get a revision, regardless of being 80 or not.
Anish, do you ever consider grafting these, or is that an option?
I got a few of them sitting around, and nobody knows what the right answer is, obviously. But I wonder, it's a dumb question. Those are cannulated screws, and we know we're getting polyethylene wear. And I wonder if the macrophages and if the poly is running up and down that hole in the screw and actually causing that hole in the cyst, causing that cyst. So I would take out those screws, and this, because he's old, right? Take out the screws, put in a couple solid screws, and I'd bone graft the hell out of that cyst. Take some bone marrow and put some juice in there and throw it in there through a tiny hole and pray to God it heals, and go down through that second one where the implant is and just fill the hell out of that thing and pray to God it works for 6 weeks non-weight bearing. I wouldn't put cement in there, though. That's another option, just to make it more solid.
Mm-hmm.
And then if that doesn't work, then as Chris suggested, I'd tell him if it falls apart and that tibia collapses, I'd revise him to a stemmed implant or a fusion or some nightmare situation at 80. But that's initially, I always ask myself, why did this occur? And in this case, without an infection, I think there's actually a tract from the joint through the screws into that hole.
Constantine, any different approach to periprosthetic, what would seem to be aseptic loosening, or not even aseptic loosening, just cyst formation due to, particulate debris?
No,
we all see this.
Pardon me?
I said, because we're all seeing this. Right?
Yeah, no, I agree with you. I think it's a fascinating. It makes you think maybe I should just use solid screws from now on. when you showed that for the medial mal, but it is it's just an interesting case, And the hardest decision is, when do you bone graft the cyst? And early, when I first started, I used to say 1 centimeter, and all cysts are 1 centimeter. So that means you have to bone graft every cyst. So, so that doesn't really work very well. Ideally, you bone graft them before the implant becomes loose, and that's hard to know when. It's remarkable how big the cyst can get, and the implant can still be stable. So that always surprises me. And then if you can see a cyst on an X-ray, it looks a lot worse on CAT scan.
Yeah,
it looks a lot worse in real life. So always be prepared for the cyst to be much more extensive at the time of surgery than you thought from the imaging. And I typically use allograft because it depends. Sometimes I have used autograft, but usually it's allograft. And I've never injected cement. I don't know if anybody mentioned cement. I've never done that, but in an older patient, that may be an option.
So that's what I did. So I injected the area, but I didn't use methyl methacrylate cement. I used calcium phosphate. There's lots of stuff from every company. Just because the guy wasn't having any pain, he has some other prostate issues. He was like, I'm not doing anything. And I was sort of getting nervous about it. So I injected it with calcium phosphate cement. I aspirated it as much as possible, but like, I don't know that I'm really getting it all out, but that's kind of what I did. And that's kind of what it looked like. I mean, and you can see some of that crap comes out from the injection site. This is now 8 years post-op, and now 9 years post-op, and now he has pain.
Right.
And here's his CT scan.
Oh, yeah, look at the talus.
Yeah, so I don't know that I've made him like worse, but I certainly didn't solve the problem.
Yeah.
So back to you, Chris. What's your plan at this point? And he's like not about to die, right?
Yeah.
Like he's like, you know, he's like almost 90, but like he's like vibrant. Like he's like walking around. He doesn't even use a walker, doesn't use a cane.
Yeah.
I told you so doesn't count, Chris. You can't say that either.
Well, you know, why do a surgery at 8 years? What do you do at 9, I guess? But yeah, no, I mean, you didn't put any of the calcium phosphate into the talus, right?
No,
just native. Yeah.
No, and I did get a CT scan prior, and there was like almost nothing. It was only under the bell of and I didn't think I could even get it.
Okay. Yeah, I mean, obviously, you know, I don't think you can wait any longer. It's hurting. I was, you know, obviously we still, I think at the revision, you'd still culture and biopsy everything just to make sure. But these look, you know, kind of like the normal, just very large expansile cysts that we see with polywear, et cetera. But now, I mean, the talus is very concerning because there's a very large defect.
All right, so go. So what are you putting in, or what are you doing?
So on here, I still like to use as much bone as I can, and not really rely on cement. If you know, with some of these revision prostheses, you know, you can span the bone a lot better and get a much wider base of support. So I would use, in this case, is probably a combination of auto and crushed cancellous allograft with BMA. Really fill in the bone, impaction graft the bone as much as I can. To get some support, I'd use a revision implant on both sides. So it's going to be a stemmed implant on the tibia, and then a revision that comes either all the way to the talar neck or maybe even across the TN joint to get some kind of a bone support.
Anish, do you think that talus is like salvageable with an implant? Can you graft that? Like, are you able to do that?
I think looking at that CT, theoretically you could. So I think ideally, because that's getting the cement out of getting calcium phosphate out of the tibia. I've done that, is no fun. So ideally I would two-stage, take the implant out, get all that cement out, bone graft both sides, put a cement space in between, or what I've done is put a femoral head in between and then try to get it all to heal, then put a revision stemmed implant in. At this guy's age, I don't think that's appropriate. So I think at this point, you either do, for reliability, and he's not going to live that much longer, you do a total talus to mitigate the risk of collapse of the implant now, and then do a stemmed implant, or just take it out and put a cement spacer in. Honestly, if he was 90, sicker, that's not a bad option either. Just put a piece of cement in and say, live your life with the brace, and I'm not going to try to hurt you. But if you really want to do a true revision, I think a total talus and a stemmed implant in this 90-year-old is reasonable, because you're never going back in this patient.
Yeah.
So I took out, like, the talus was such crap. I took out, you know, you can see the implant was completely like loose. I did a revision with a stem tibia. I did do a total talus, and I did ORA for the tibia with grafting of the tibial cyst. And this is kind of what I did. And I felt that the talus was not salvageable. And like, given his age, that this would be fine. Like, it's not going to last forever, but nor is this guy.
Yeah.
I mean, that was kind of my thought. I'd be interested in what people think. Like, did I use a plate that's too thin also? The tibial component did dorsiflex a little bit through the defect in the tibia. I did graft it. I did not do a ligament reconstruction. I just feel like this whole thing will kind of scar in. No TAL, and sort of how long would you guys make this guy like non-weight bearing? Constantine, you can start if you want.
These I'm a little bit slower in the progression, so I'll do 6 and 6 and let them scar in, and I'm not so worried about range of motion. I do see the the drift and the stem happen in revision cases, particularly when you have bone loss and defects. So that certainly happens. And I think the hardest decision for me in this case is, what do you do about the subtalar joint, and do you secure the implant to the calcaneus or not? There's obvious pros and cons to both. I've seen patients do well with this. I've seen patients develop pain at the subtalar joint 2 to 3 years later. And then it's hard to take them back because oftentimes they're older and you don't want to have another operation. I've had to revise a total talus, and it's not so difficult because you take the poly out and all of a sudden you have plenty of room to take the implant out. So it is doable. But I wonder what everybody else's thoughts are to anchor the talus to the calcaneus. I will say that in recent years, I've done it every time. And I have one patient now who has persistent pain there, and it's hard to know if it's healed or not, because every time I get a CAT scan, the metal looks like it's touching the bone, the screws are not broken, but he has pain, and I don't really know what to do. So
so you're talking about making like an ingrowth surface on the posterior facet of the implant, and the screws that go through it, like, so doing a subtalar fusion.
Yeah, and what I tell patients is, when this comes up, I say to them, you know, you're going to get a custom talar implant anchored to the calcaneus, because fundamentally that's really what they're getting. Sometimes I'll shorten the neck so that there's a little bit less stress on the navicular, maybe about like 1 millimeter or 2. Depends on the circumstances, but I try to avoid fixing it to the navicular, because I think that's asking a little too much. But
yeah, I agree. That's the concern I've had with these is you know, exactly what you said. What if you have a late term subtalar arthritis, subtalar pain? You know, you can't just go in and fuse it. I mean, it's a polished surface, and there's nowhere to put screws. So I've gone to anchoring all of them. You know, having a porous surface on the other side, bone grafting that, and then having screws across it.
And then what, non-weight bearing for a couple of months, Chris?
Yeah, because now I'm trying to, like you said, I'm not even sure I'd call it a fusion, but I'm trying to encourage this, at least bonding of it to the calcaneus. So I'd usually non-weight bear them for 6 or 8 weeks at least, probably 8 weeks, and then be a little slower in the progression from there.
Interesting. I haven't had a bunch of patients yet that have posterior facet type of complaints after a total talus, but that this discussion will give me a little bit more pause in my thought process as we move forward. All right, next case. Anish, you want to just sort of go through this case, please?
Sure. So this is a prior star, which I didn't do, but it doesn't matter. But do you have a couple issues here? It's one stage. If you look at this for everybody here, he was doing well for a year. The surgeon who did it said he couldn't get the deformity corrected and did this, which I think is fundamentally an issue. So you have residual cavus with subtalar valve, is what Hinterman talks about, that peritalar instability, implants in varus, and he hurts a lot. And so the question is, what are you going to do? It's only been a year out, or a year and a half now. He hurts a lot. His foot's still deformed. Young guy, he's like 40 years old. And implants obviously loose on the tibia, subtalar non-union, or not even tried to get a union, with persistent deformity. So the question is, how do you approach this? Are you 1 stage? Are you 2 stage? I assume everybody here is going to revise the implant in some way, shape, or form. So Dave, I guess that you've been doing all the presenting, why don't you answer? Why don't you go first?
So, you know, obviously he has, you know, a varus hindfoot with a non-union of the subtalar joint, both of which need to be corrected. I correct that with a lateralizing calcaneal osteotomy. You know, I remove that hardware, lateralizing calcaneal osteotomy, and repeat subtalar fusion. I would try and see if we could sort of keep those screw holes, you know, because I don't want to take out a ton more bone. As it is, that star will have gotten rid of a lot of bone. I'm going to go to a flat cut tibial component. I'm sorry, the flat cut talar component with a tibial, with a stem tibial component, but it doesn't have to be like an in bone. It could just be a salto. I completely take off the deltoid ligament. So I skeletonize the medial malleolus back to the posterior tibial tendon. I will I will completely detach the talonavicular capsule. I'll put a cob in there and make sure that it's completely free so the talus can, instead of being up like it is, it can plantar flex, like as if it's going into more planus. And then obviously just like the normal things that you would do otherwise, which include like cava varus reconstruction, peroneus longus to brevis transfer if needed, plantar fascia release, dorsiflexion osteotomy of the first ray, based on, what it looks like. And sort of echoing what Constantine had said earlier, we just need to make sure this isn't infected first, but that would kind of be my approach.
So basically all one shot.
So
that's the other question I think we have to ask.
Yeah, the thing is like preparing that subtalar joint. Yeah, I mean, I guess you need to be prepared to figure out what to do with that talar implant once you take it off. I mean, you could do this in 2 stages. It's a lot of surgery to certainly do at 1 stage. If you do it at 2 stage, you could just do, a sinus tarsi approach and then all your hindfoot and forefoot work, and then come back later and do. I guess it would just depend on the patient, their body habitus, and like how their ankle looks visually as to whether or not I'd stage it. But it's a lot of surgery at once. I'd be more inclined to stage it.
Stage it. Chris?
Yeah, I was going to say I'd probably stage it just for me because I think the foot's involved a lot here. I mean, we can't see the full lateral or anything, but I think that's a lot of cavus into the very varus medial column. So for me, I would prefer to, remove the implant, get the ankle neutral, pin it there, put cement in there, and then I've got a straight ankle, and then I can work my way down to the foot and get the foot out of varus, whatever I need to do, medial column wise, and so I can build everything around it. I do the tendon transfers and the repairs laterally all then, and then let it cook and heal, and then that way when I come back for the replacement, it should be just a straight ankle and a really easy swap. Not easy, but an easier swap because we're going right to the revision implant. But I would stage this one, particularly since it's already been tried once and didn't work out well. We want to make sure we get it right.
That was my thought. Can you go to the next slide? That's a CT. I don't know why I didn't put the full foot X-ray in there. Can you go to the next slide? So I did what you kind of said. I did a triple. I'm a big fan of a triple for a revision cavus because I don't think the hindfoot does anything at this point. So I took everything out. Next slide. Cement, just like you said, pinned it, get everything where I want to go. Next slide. And then did my triple and the cement spacer to hold it so that I can put my stem implant in.
That looks great.
Yeah.
Thank you. And then let's go to the next one and see what Constantine says. So now at this point, the cement's doing whatever, kind of hanging out in there. I found that they hate this part of the case. This like intermediate phase, they're kind of like not mad at it, but it hurts. And how long do y'all wait, Constantine? So now you got a fusion. When do you decide to put the ankle in? Because I've kind of gone back and forth. I just make up 6 months. I get a CT, and if I see bony union, I think I'm safe now to go back in and do it. But it's a long time.
Yeah, I wait at least 6 months. I think 3 months is too soon because the bone may look healed, but it's still healing, and the soft tissues are still, swollen and agitated. And I think 6 months is the earliest. I always hope that they're happy with their cement spacer, and I've always been disappointed. So I've yet to find my happy cement spacer patient. I'm still looking. So I wait 6 months, and if they can tolerate it longer, let's say they have a life event that is important to them, then I think there's benefit to waiting. Everyone worries, is the cement going to do this or that or damage? I think them loading their ankle is good for the bone. I have had one patient who, because again, the cement spacer doesn't hold the ankle perfectly straight. At least I haven't been able to do that. So I had one person develop a stress fracture in the medial distal tibia while they were on the cement spacer, but that was okay. I mean, I ended up actually was healed by the time I did the revision ankle. So I think I just may have put a screw in or two.
Yeah, you leave. I I leave a 2-4 Steinman pin in there from the tibia, almost kind of vertically from the front of the tibia into the posterior part of the subtalar joint with the cement around it. I did that because I had 1 or 2 of the cement spacers start to extrude out forward when they started walking on it and things like that. So I started kind of doing the combo, the pin and the cement, and that seems to really work. They don't complain of pain at all. I think it's stable enough that they don't hurt. It doesn't move, obviously, but it doesn't hurt. And then that way they can, most of the time I'm going back really closer to that 3 or 4 month mark, mostly just because they're over it. They want to get to the next step. They've been waiting, and then they're usually at 3 or 4 months, they're not too swollen. And I always get a CT, make sure that it's healed up enough bone wise before we go. But that pin cement combo seems to have helped some of the pain part.
So I revised them. It's in slight varus. Once you make that drill hole and you screw it up, you buy it, right? I should have taken my reamer out, readjusted, prophylactic to the medial mal screw. Implant sat pretty well on the talus. It wasn't perfect. I didn't go to the revision tailor stem because I thought I had good tailored bone stock. And then he's at 3 years now. If we want to go to the next slide, ended up looking okay. I argue that clearly that implant is not. This was a while ago, but I should have put that more straight. But he was obviously relatively happy from where he started. He'll do fine. Obviously, he had to prophylactically fix the medial mal so he doesn't get a fracture. I could have, and I wonder if I should have done a fibular osteotomy to spin it around a little bit, besides putting the implant in straight. Right?
I think it looks good. I think you're being very critical. I mean, and obviously we can always, Monday morning quarterback. It is, obviously the stem's in a little varus, but I think they're going to do okay.
Yeah, that's the funny thing. I think these people do fine. I think when we present, I always like to be hypercritical of what we do because I don't like to say it's perfect if it's not. Sometimes I do get perfection, but it ain't always. So I think, I'm more aggressive now about blasting the fibula and swinging things around for these subtle varus cases. And then the other question I have is for you guys is when do you do an anterior tib tendon transfer on cavus? This is not exact. So the revision case, they're in a lot of varus. You do all this work, and do you do a tendon transfer at the same time, like an anterior tib? I've done that once, the lateral cuneiform, or do you take the push tib at the same time? Because that dynamic aspect of it, if you're doing a one stage, when do you do it? Because the problem for me is how do you close the skin?
Yeah.
Hard time.
Yeah. I haven't done it at the same time.
No, I have not either.
Yeah.
All right. So it's not just me. I tell them I'll wait. And in 3 months, if they're still kind of swinging, I'll go back and flip it around.
Yeah.
No, that's a tough decision making. Tough decision to make. All right, Chris.
Okay. Yeah. Thanks. You can go to the next slide. All right. So 53-year-old lady comes as a second opinion, wants a TAR. She's already had a couple recommendations for fusion and just wanted no part of that. She stands a fair amount as a pharmacy tech or something. So she's got a valgus ankle, but a flat foot underneath, and a lot of pain in the ankle, particularly kind of subfibular impingement from the heel and then also up at the joint itself. So you stress her. She's certainly got kind of a lax deltoid. You can feel it. She's got a flat foot when you see her stand. So this is, a complicated case. I've always been very timid on valgus ankle, especially earlier in my career, and try to do some of these rebalancings and just didn't ever seem to be super thrilled with them. So I've certainly adopted kind of Steve Haddad's ideas of staging, particularly on valgus if I can. So you see her, she's arthritic, she's painful, and again, kind of looking at the foot, doesn't look awful there, but it's certainly a very flexible flat foot. So next. So this is kind of back to that kind of staged idea. With these, I'll use the cement as kind of a wedge. So if it's valgus, it's lateral. If it's varus, it's more medial. There's the pin that I kind of cut and bury and kind of flatten it on the front of the tibia. And again, that's just a temporary thing. So then I can build the foot around the straight ankle, essentially, in varus valgus. It's probably a little more plantar flex than I like to pin them, but So we did, since it was flexible, but had arthritis in the subtalar, we did a subtalar with a calc slide. So that was me trying to push the axis a little more medially, FDL transfer, and then kind of a synthetic augmentation for the deltoid. So kind of a double bundle deltoid from the medial mal to the sustentaculum to the plantar talonavicular joint. And so then that kind of cooked for a couple months, and then weight-bearing CT showed good healing of the subtalar. So we can come back, and then did the kind of minimal resection ankle replacement. And actually everything really kind of seemed to be clicking along well, no real problems. So that's our primary. That's about, right about 4 months, I think. You can go to the next one. So pretty uneventful. She's probably about a year and a half here. I start noticing a little bit of lucency over that lateral peg of the tibial implant, but no pain. Very thrilled, happy. She's back to work. I kind of tell her, this is different than what we saw before. We'll kind of keep watching this. I've talked, lots of our colleagues kind of say, what do you do when it looks like this? It doesn't hurt at all, but clearly that's different than what it was earlier. So I just kind of keep watching her. And then the lower picture there is at 18 months. And now she's saying, hey, it's swelling a lot. It's never red. It's never, erythematous, but it's swelling more. And now she's talking about pain. So I say, well, honestly, I probably put my head in the sand a little bit and said, well, it's, maybe you're just working too much. Let me put you on some Celebrex and hopefully it's going to be okay. But, I watch it a little bit more, another about 6 months, and you can clearly see that the tibia is getting very loose. So all the infection workup that we've already kind of talked about, everything was negative. So this is, this really was an implant that just became, osteolysis became worse. And now you can see the entire thing is loose. So I guess to you guys, it's sort of like your case a little bit earlier, Dave. I decided I got to pull the trigger because it's clearly progressing, and then her symptoms are progressing as well.
Yeah.
So I guess first question would be, in a staged implant like we did, does that affect implant selection when you come back to do the implant? And that's something I, looking back at myself, should I have maybe done a stemmed implant right off the bat since it was a staged implant versus a minimal resection implant? I don't know if that was the reason or not, but
Constantine, did you guys have a database suggesting that maybe a stemmed implant in a staged procedure would last longer? Did I hear that at a meeting once from one of your residents?
Not necessarily staged, but we just did a paper that's available online that was accepted at JBJS, and it showed similarly at like the study at Duke that subtalar arthrodesis is an independent risk factor for failure of the lower profile tibial components, and that a stemmed implant or a keeled implant reduced that risk of failure by 95%. So then you say, well, I'm always going to do stemmed implants, and then occasionally you see one of your patients at 2 years that doesn't have one and is doing great, and then you go, well, gosh, maybe it works,
Yeah.
and then you get one of these cases. So
yeah,
not an all or nothing, but it's intuitive that more metal is more stable, and when the hindfoot is fused, it's more stress at the ankle joint.
Yeah.
The other thing that kind of frustrates me is there's a ton of systems out there that if you get failure of one component, revising the other component's not an option.
Yeah.
Do you know what I mean? Like, so here, this, in the Cadence, there's no revision tibia component because your talar component's fine.
Yeah, you think with the subtalar fusion, you're worried it'd be the talus is going to be the problem, right? It's going to subside, the bone's going to be weak or something like that. And this is a chamfered talus on top of it. But yeah, exactly. There's no way to mismatch the implant or go to a revision tibia and leave my talus alone. So
well, you've got plenty of bone stock to work with. So
yeah. So you can go to the next. So obviously, as we talked about earlier, you get CT, it's always worse than you think. So we're getting a lot of bone loss, and I think that's my argument sometimes to get on these a little sooner than later, because the longer it sits there and swims in the tibia or the bone, you're just getting more and more bone erosion, which then makes the stage or the replacement revision even harder. So you can kind of see that's what I'm pointing to with the arrow there. By the time I got the tibia implant out, she had really ballooned around it quite a bit, and there you had this almost expansile loss in the lateral tibial portion there. So, thankfully with a stem, that part of the bone isn't super needed. I didn't want to bone graft that necessarily and have bone sitting in the joint, so I kind of just left it. And interestingly, you usually kind of see that remodel again once it's stable and you don't have the implant banging against that side. But I was able to do just a primary stemmed implant. I didn't go to a revision one. So that's her at a little bit over 2 years.
That looks great.
Another slide there.
Chris, did you one stage it or two stage it, man?
I did it at one stage. I was pretty confident she didn't have any infection, and so I did it at one stage. I'm
a baby. Even when I see that, I always tell them, I'm on a two. I am a baby about it. It's two stage cultures, bone biopsy, cement, and universally not infected. That's but I'm not confident enough to be. Maybe because in Chicago, if they are infected and now they lose their leg because of my stupidity, I don't know. I don't think.
No, but your point's valid. Well taken. I think that's probably pretty smart. I probably let her bully me a little bit. She was just so over this whole process.
No. I mean, I'm pretty confident this is mechanical wear, just like you guys have said. So maybe I'm being too conservative.
Yeah.
It's extra surgery.
I think I'm very. I try to be very tough in my stance with patients on this, but I agree with you, Chris. You burned your two-stage capital in the first case.
Yeah, right.
Now they're looking at you like
that's true.
And
100%.
And that
100%.
You have to take that at some point into consideration. So I would have done the same as you did, and I would have done it as one. And
Okay. Thanks.
Great. That's a great case, and all those learning points are. Oh, I didn't see that X-ray.
Yeah, that was right before I took it out. So that's then now you're seeing it. We had already made the decision we were going or whatever, and we got another X-ray. She came in for another talk. I'm like, okay, this thing's falling out of your ankle if I don't get to it. So it was no question about it at that point. But just kind of the same points I think we talked about. Even not all osteolysis is benign. It doesn't always stay the same. It certainly can worsen over time. So if you see it, keep an eye on these people. And again, that third point I think is maybe the point I'm in my own career. I'm probably getting a little bit more aggressive to revise these sooner rather than later, because I think it makes the revision harder or worse if you really let bone get destroyed.
Good points. Awesome. All right, Constantine, why don't you take us through what we have here?
I like that intro slide, Dave. That's better than mine. I'm gonna have to steal that from you. That looks good. All right. So I'll be brief. This is a patient that came to me. She'd had multiple prior surgeries, and you can see on the left side she has a mismatched implant. So that there's trouble when you see that, but both implants are mobile bearing. She has multiple medical comorbidities, obesity, diabetes, chronic kidney disease. She's not a smoker. She comes in a wheelchair, can't stand, can't walk. She had already seen my partner who does reconstructions with ring fixators, and he said that she was not a good surgical candidate. And, again, that's another warning sign that we're in trouble. But she has painful ankles on both sides. Skip to the next slide there. There you go. And those are her laterals. And so how do you tackle this problem? And
now your day's ruined. Like your clinic is like going to be completely thrown off.
Yeah. And of course you do, the AFO, hinged AFO brace, and you really maximize non-surgical management, and you do all of it. But ultimately, you got to get people out of a wheelchair if possible. And so we started with the right side because that was the easier side. And I've really enjoyed the discussion of everybody with 2-stage and reconstruction and correction. But we're going to be in this situation a little bit more modest in our expectations. And I just need her to be able to stand and walk. So I'm not going to go for a home run. So show the next slide. So here's the before lateral, and go to the next one. And then this is her initial, an earlier standing. You can see she's not really standing. But you can see here that I did this as a single stage revision where I took out the implant. There was a wafer of bone posteriorly on the talus, and I propped it up with those 2 screws. I used some of the bone from the distal tibia to bone graft the subtalar joint. And click the next slide as well. And there you go. So it's an augmented tibial component as well. And we're going to ride this out. And I'm not going to get a CAT scan unless those screws break. Okay.
Yeah.
And of course, unless she's having pain. So she's doing well. And here's the other side. And on the other side, there's just not enough calcaneus, really, in my opinion. Now, of course, you can design an implant that fits in there. Of course, the engineers will come up with a solution and sell you a $10,000 total talus. But let's just use some common sense. Now, she's not a good candidate for healing of an allograft. But she's, again, not a good candidate for anything. So this is a posterior approach to remove the implants, make a flat cut on the calcaneus, use a femoral head allograft, preserve the malleoli and bone graft adjacent to the allograft. So worst case scenario, you might get some bone bridging around the implant. You can see here that this is a rigid nail, and that allows me to put a posterior plate. I think these patients need as much fixation as possible. So go ahead to the next slide, Dave. There you go. So there's her. And again, the foot's not perfect, but the foot's good enough.
Yeah.
And go to the next slide, if you would. And there's an ankle where you can see the lateral is a little bit more weight bearing than the earlier one. And again, the arch, the arch is much better, you know. Yeah. And this lasted her, and she passed away a couple of years ago. But she was able to walk, and it wasn't perfect. And she was in an AFO brace on the left side. And a lot of these femoral head allografts, I tell them, you're gonna be in an AFO, a fixed AFO, because that graft can break. And we've all had them break. I've had mine, and they need support. So, and she was compliant, and thankfully, again, we only show our good cases, unless it's a complicated.
That's a great save.
Well, guys, I'm going to unfortunately wrap this up, even though these are fantastic cases and great discussions. This is awesome. Great salvage there, Constantine.
Yeah, great cases.
Yeah.
Good work, guys.
All of you guys. Appreciate it. Thanks, guys, for your time. Hopefully you'll kind of watch some of the other stuff going on today, but I appreciate it. And thanks for those awesome cases.